good afternoon. My name is Ahmed. I'm one of the trainees here in this department.
Hello.
Hello.
Today we will discuss with you a female patient that have a 16-week fibroid and she has a previous 2 cesarean section. So please, Ahmed, can you explain for us why do you prefer to do hysterectomy for such a case?
Well, thank you so much for your question. So this patient must have tried everything to control the bleeding. She has heavy menstrual bleeding.
Yes.
Myomectomy or hysterectomy will be the definitive treatment for this patient, right? I don't think that medical management of fibroid will be of any help to this patient because of the huge size of the fibroid, and the interventional radiology like the uterine artery embolization and the focused ultrasound would be indicated for specific patients.
Yes,
So
and
yeah,
with this large
this
fibroid,
with this large fibroid. So the
it will be
definite
difficult.
treatment would be myomectomy or hysterectomy, abdominal or laparoscopic.
Okay, so we choose that we will do hysterectomy. So what is the pre-operative preparation that do you think that we have to
Okay.
do?
So first I need to check for the cross-matching, the APO cross-matching with the patient, any
Yes.
history of allergy, go through the consent, make sure that the consent was well informed, that the patient really understand what will she'll be going through, and do the basic investigations like the CBC, hemoglobin, make sure that the patient is well fit for the operation, and to go through the enhanced recovery program,
Yes, it's
right?
very important.
Very important, yeah. So patient should be well hydrated. She
Yes.
should attend at the time, at the date of the operation itself, and should minimize the starvation, like
Yes.
2 hours for fluids and 4 to 6 hours for the food, for the solid food.
Yes. So now we are on table.
Yes.
So what you will check?
I check the handband for the patient, like to make sure that this is
Yes,
the
it's very
exact
important.
patient that we should do the hysterectomy for.
Yes.
This is the WHO checklist. This is the sign in, sign out to introduce myself to the team, to get familiar with the team, make sure this is the patient itself, that herself that we need to operate on,
Yes.
and allergy
Examination
check
for it?
and do examination for the patient, right?
Yes.
The abdomen examination for the patient.
So and after
Then
that?
the scrubbing and draping for the patient. I would ask the patient first the day before surgery to take a shower with chlorhexidine based soap. And for myself, I would do the scrubbing, the scrubbing using chlorhexidine alcohol based.
Yes.
Yeah.
It's very good that you tell us about it. So what you prefer, the betadine or the
There is,
chlorhexidine?
as per the NICE guideline, there is no evidence that any of the combination is
Superiority
superior,
for
superior to
yes.
the other. But uh, the rank is like this. So chlorhexidine alcohol based, chlorhexidine water based, then povidone alcohol based comes first, then next comes the water based.
So okay, we will start the operation now. What the blades that you prefer to
I would use the
use?
convex blade. This is number 2020 or
Yes.
22. Convex would be the best one to go through the walls of the abdomen,
Yeah.
right?
Okay, this is right. So which incisions that you prefer to?
We have many incisions for this patient. We have the longitudinal midline incision. We also have some transverse incisions,
Yes.
right? Longitudinal incision would be the best for exploration. Maybe could be better for this patient because of the huge fibroid.
Yes.
And we have the French teeth incision, which is the most commonly used incision in pelvic surgery. And also we have the joint coin incision, which is the true muscle cutting one. And we have the joint coin is transverse, but it's not a muscle cutting.
Yes.
Muscle cutting is the cutting in the maillard.
Okay, so we will start now the operation and we did the skin incision. What is the steps that you will do?
So after cutting through the skin, the subcutaneous and the rectus abdominis, the rectus sheath, and separating the rectus abdominis, suppose that we're doing the transverse incision,
Yes.
right? Now comes to the transversalis fascia and the peritoneum. First thing we need to do is this is the previous uses resection. Patients should take a great care
Yes.
while entering the abdomen because of maybe the blood because a lot of adhesions.
Adhesions.
So yeah, we may not to injure the bladder and the bowel. So need to make sure that we are doing step by step.
So you have an important structures that you have to identify when you are
The anatomy,
dissecting.
yes. So the anatomy. So first need to identify the anatomy, the fundus, the tubes, round ligament, and the ovarian ligaments.
So
And
what's the instruments that you will use and make it that easy for you for your dissection?
So we have dissection and devascularization.
Yes.
So dissection, I would use the for the bladder itself, the toothed forceps. Okay, to hold the bladder, and use the medicine boom scissor, right? This is the blunt one, what helps to dissect the blood, because this is a previous use as an section patient. I wouldn't think that blunt dissection will be better, so we need to do sharp dissection.
Yes.
Right.
Okay.
This is for the dissection. For devascularization, I would need to cut through the ligaments of the uterus. We have the round ligament, we have the ovarian ligament, and we have the cardinal ligament and the uterine.
Can you illustrate for us what you will use for that?
Yes, for the ovarian ligament, this is the vascular pedicle.
Yes.
So I need to use something like the Gilliam clamp or the Haney clamp. Something that would, hold in place and would, wouldn't slip, like the Haney clamp. Every time I would use double clamping and double suturing, right?
Yes.
So two clamps. Yeah. So now we're done with the ovarian. Then comes the broad ligament. You might cut it using something like Zibelin clamp, which is used for non-vascular pedicles, like the broad ligament and the cardinal ligament. So for the cardinal ligament, I would use also the zip-line clamp. Okay. For the uterine artery, so the next devascularization, I would also use the Haney clamp or the Gilliam clamp.
Yes, okay.
Then comes now I did the devascularization, and also now I have a proper dissection. I would use this one. This is the Vertime Culling clamp. I would use it to hold the vault in place. Yes. And cut just above it. Having done with this, I would hold the vagina vault.
Yes. And
using some Alice's. Right? Some Alice, and do interrupted suturing of the vault.
Before we come to the vault, I would ask you, if you have a stuck bladder, what you will do?
I would call for help from my consultant, from my senior. If we couldn't do it, if we suspecting like we could do bladder injury with dissection, with the sharp dissection, we would call the urologist.
Yes, okay.
He would come and do this for us.
What do you think is better to identify the ureter? Know that the incision may cause an injury, and it is a common complication that we face.
Yeah. So the risk is 1 in 1,000.
Yes.
To injure the ureter, to either the ureter or the bladder. Overall serious risk for the hysterectomy is 4 in 100.
Yes. And
to identify the ureter actually first I need to know the anatomy. It comes from lateral to medial, crossing over the common iliac bifurcation, yes. Just lateral to the sacroiliac joint, then downward medially all the way to the bladder and crosses just beneath the uterine artery, 2 centimeters above and lateral to the internal os. And direct visualization of the ureter would be better, so I need to see the peristalsis around the uterine artery.
So when it crosses what is the other measures that you have to take care about it after we are finishing the hysterectomy?
Inform the anesthetist, right? Inform the consultant, make the nurse to count the swabs and the instrument, the needles, and to check the pedicles, the ovarian, round, uterine, artery pedicle and the cardinal ligament pedicle.
And the catheter
And
also.
catheter and the bladder. And also I need to make sure that there is no bleeding, to do estimated blood loss. If there is any, more than usual blood loss, like might also, tell them to, do blood transfusion.
Very well. And so what about the post-operative care that
So
you have
post-operative
to?
care, I would, close monitoring with the vital signs for the first 2 hours, VTE rescue assessment if she needs any thromboprophylaxis for the patient, ask the patient for encourage early mobilization, because this is also a part of the enhanced recovery program, antibiotics, analgesics, debriefing with the patient, documentation. This is for the post-operative care.
Thank you, Ahmed. We are very happy that you illustrate that for us.
Thank you so much.
Thank you.
Thank you.